Welcome back to the Explainer series, everyone. I'm Harshal, and today we're jumping right into part 70 of Decode Healthcare. We're officially entering Chapter 2 of the CMS ICD-10-CM official guidelines to deliver a zero-fluff, highly actionable masterclass on neoplasm coding laws. Seriously, if you've ever second-guessed which code legally claims that coveted first slot on your claim form, well, this explainer is exactly where you need to be. Here's our roadmap for today. We'll be covering primary versus secondary focus, sequencing complications, chemo and radiation encounters, and active cancer versus history. Section 1. Primary versus secondary treatment focus. Now, this rule fundamentally dictates what goes into slot number 1 on your claim form, which is your principal or first listed diagnosis. Imagine you've got a patient with primary breast cancer, but unfortunately it's metastasized to the brain. If the physician's treatment during this specific encounter is directed at the primary malignancy, so the breast cancer, you sequence the primary site first. Bam, you put a C50 code right there in slot 1. But if the treatment is directed solely toward the secondary metastatic site, the brain, you absolutely must sequence that secondary site first. That means C79.31 takes the lead, even if that primary breast cancer is still very much active and present in the patient's body. Crazy, right? So, the absolutely crucial takeaway here is this. Whatever specific site the physician is actively treating during that exact encounter, that's what claims slot number 1. It literally doesn't matter which cancer originated first, it only matters what is being treated today. That is the golden rule of Chapter 2. All right, moving on to Section 2, sequencing complications, specifically anemia and dehydration. This is a strict CMS rule you absolutely have to memorize. If the admission or encounter is for the management of anemia, and that anemia is caused by the malignancy itself, the cancer leads. You code the malignancy first, followed by the anemia. Specifically code D63.0 for anemia in neoplastic disease. But what if the encounter is for anemia caused by an adverse effect of the chemotherapy? Well, in that case, the anemia takes the lead. For chemo-induced anemia, there's a very precise 3-code sequence you must follow to remain completely compliant. Step 1, code the anemia first, since that's the primary complication being treated today. Step 2, code the neoplasm. Step 3, code the adverse effect, which is your T code. Specifically, you'd use a T45.1x5A code for the adverse effect of anti-neoplastic and immunosuppressive drugs. You really can't mix this order up, or your claim just won't reflect the guidelines. Now, let's apply a similar logic to dehydration. If a patient is admitted solely for intravenous rehydration due to the malignancy, the dehydration strictly takes slot number 1. You code the dehydration first, followed by the specific codes for the malignancy. Because the entire focus of the encounter is rehydration, the dehydration wins that principal diagnosis slot. Section 3. Encounters for chemo and radiation. Okay, let's look at this quote straight from the CMS official guidelines. This establishes absolute authority. It says, if a patient admission or encounter is solely for the administration of chemotherapy, immunotherapy, or radiation therapy, you assign the appropriate Z51 code as the first listed diagnosis. So, when they're admitted solely for that therapy, Z51 is the law for slot number 1, period. To break that down logically, you sequence the Z code first to explain the exact reason for the encounter. For example, you'd use Z51.11 for anti-neoplastic chemotherapy, or Z51.0 for radiation. Doing this intentionally pushes the active malignancy code into slot number 2. Think of it like this. The therapy is the why they're here today, and the cancer is the underlying reason they need the therapy. Section 4. Active cancer versus personal history, also known as the Z85 category. Now we arrive at the million-dollar question, when do you actually stop coding the active cancer? Knowing exactly when to sever that active cancer C code from a patient's chart is incredibly critical for submitting clean claims and, of course, preventing those dreaded compliance audits. Let's look at the official definition. We use a code from category Z85 to indicate a personal history of a malignant neoplasm. It points specifically to the former site of a malignancy that has been excised or eradicated. But, as with pretty much all things in medical coding, using this history code comes with incredibly strict prerequisites. To completely strike through that active C code and switch to a Z85 history code, 3 things must be true. 1. The primary malignancy is totally excised or eradicated. 2. There is absolutely no further adjunct treatment, like ongoing chemotherapy or radiation, directed to that site. And 3. There is no evidence of any existing primary malignancy at that site. All 3 boxes must be checked. And here's a pro tip straight from the guidelines. You only use these specific Z85 codes for the former site of a primary malignancy, not a secondary one. The boundary here is super clear. Even if the surgeon successfully and completely removed the tumor, if the patient is still receiving active adjunct chemotherapy, you still code the active cancer. You definitely don't use the history code yet because the treatment is ongoing. It's only when the tumor is gone, and I mean completely gone, and there is 0 adjunct therapy happening, that you finally transition to the Z85 history code. Basically, active therapy equals active cancer. So you really have to read the clinical chart carefully to know exactly when active therapy stops. That wraps up our explainer on neoplasms and Chapter 2 guidelines. You've officially mastered these sequencing rules. But let me ask you this. Are you ready for Chapter 4? Do you know the sequencing rules for long-term insulin use versus hypoglycemia? Make sure to hit that like button, subscribe, and get ready to tackle the endocrine system with me in Part 71. See you there.